Hello dear students, welcome to the November 2024 INI-CET recall questions for the subject of biochemistry. So this time biochemistry was not very difficult, but the problem is they shifted the question paper mostly in minority to that of laboratory kind of biochemistry. So because of it, some students might not have been able to answer the questions very well because they might have focused much on the theory part. Don't worry. If you learn this also, it can be very supportive for your NEET PG preparations for the next year also. So on that basis, let us begin with the session. All the MCQs are as recalled, and we will be having only certain questions with complete options. Sometimes the options may not be absolutely right. It is completely from the recall shown by the students. Now let's go for the first question, a laboratory based question. For analyzing the plasma or serum for electrolytes, the blood is collected in which tube? The moment they say serum, remember, serum means you have used up the coagulation factors. It means clotting has to be activated. Either you have to use the vacutainer, that is vacuum containing container, which is either empty or coated with silica particles so that clotting can be activated. So you will be using red topped or red capped vacutainers when it has to go for serum. Now for the remaining things, in case of plasma, you can go for green capped container. Green capped container is meant to contain lithium heparin. The lithium heparin is the anticoagulant so that plasma can be generated, and we can use this for estimating the electrolytes. Now there is a question. The green capped container will not be used in which estimation? The answer would be estimation of lithium, especially in case of psychiatry samples where you're looking for total or therapeutic drug monitoring. In case of lithium, you have to use a sodium heparin or a potassium heparin and not the lithium heparin. So on all other electrolyte estimation, lithium heparin is the best answer. Yellow capped means to say it is meant for containing a gel. Gel comes to supply and have a difference between that of multiple layers after centrifugation, and this gel has been mostly used in microbiology and antibody based estimations also. It can be helpful in case of hormonal assays also. Lavender and gray, they both have been used in different situations. Lavender is containing EDTA, while gray is known to contain sodium fluoride. Now knowing this will help us answer the next question. Look at the next question here. Which anticoagulant is used for collection of blood to estimate HbA1c? And the answer is EDTA containing sample. And if the sample, if the vacutainer contains EDTA, it is lavender capped. The purpose of EDTA is to chelate calcium, and also it is capable of stabilizing the RBCs. So once the RBCs are stabilized, then when the hemolysis happens, you will be able to extract the hemoglobin out and then estimate the amount of hemoglobin present inside. So for that reason, you will be requiring EDTA. Then sodium fluoride is present in gray capped containers, right? Why sodium fluoride is used? In case of estimation of glucose. If they say plasma fasting glucose estimation, you have to go for sodium fluoride because sodium fluoride inhibits the enzyme enolase, and because of which it indirectly inhibits glycolysis. Why should you inhibit glycolysis? See, after collecting blood, if the glycolysis continues to happen, then the glucose is consumed, because of which by the time you measure the glucose, then the glucose will be falls low. That is the reason why you do not want the glycolysis to happen. So sodium fluoride containing container would be the gray capped container. EDTA is actually made up of lavender, and sometimes lavender is also used in case of ammonia estimation. EDTA samples are used in case of ammonia estimation. EDTA is also an anticoagulant, heparin is also an anticoagulant, citrate is also an anticoagulant. In case of coagulation studies, you may be using citrate. Let's go for the next question. Which enzyme has not been used in genetic engineering? It's a very simple question. The most common answer is isomerase. But when you look at phosphatase, what exactly does a phosphatase do? It causes dephosphorylation. Now, dephosphorylation, how does it play a role in genetic engineering? If I say ATP is becoming ADP, it means you have removed the phosphate from this kind of ATP compound, which is a nucleotide based compound. So in that aspect, a phosphatase is capable of removing the phosphates from the DNA or RNA, which can prevent unwanted ligation of vectors, or it can also aid in cloning procedures. This is for the first option. Now, CRISPR-Cas, there is no E here, it is CRISPR-Cas. This CRISPR-Cas is a precise gene editing tool. You will be able to introduce precise double strand breaks so that you can go for gene insertion, deletion, or various kinds of modifications. What does terminal transferase do? Look at this part. A terminal transferase is used in genetic engineering where you can add nucleotides to 3' end of DNA molecules. Or you can remove something from here and give it to another DNA molecule or an RNA molecule also. So this also can be helpful for tailing or N labeling using any kind of labeled compound at the end. So these are all examples of manipulation of DNA. So we have given the best examples of manipulation using phosphatase that causes dephosphorylation, helps in preventing unnecessary ligation of the vectors and also aiding in the cloning procedures. When you go for CRISPR, it can go for precise gene editing in the form of gene insertion, deletion, and modification. And if it is terminal transferase, it is capable of adding nucleotides to the 3' end of the DNA molecules, where it helps in tailing and end labeling. But the only one that is not actively involved in manipulation of the DNA would be isomerases. So what does an isomerase do? The isomerase is capable of catalyzing rearrangement of molecules. Within a molecule, atoms also can be rearranged. So you can convert one sugar isomer into another sugar isomer, which will not play much of a huge role in manipulating the whole DNA per se. Even in worst case scenario, isomerase may also be used, but among the four options, the least commonly used in genetic engineering has to be isomerase. For that reason, we choose option B. Okay, which amino acid donates nitrogen to sodium benzoate? See, sodium benzoate can be used as a preservative in many food substances and also cold drinks or beverages. So whenever a human being is actually taking benzoic acid in the form of sodium benzoate, it can come through processed foods. At the same time, benzoic acid can have antimicrobial property, an antifungal property, to be precise, where it can help in scabies also. Now, when benzoic acid content is increasing in the blood or inside the skin and it has been absorbed in the blood, that benzoic acid has to be metabolized and it has to go through a concept called as detoxification, which comes under the precise chapter of xenobiotics. And this is traveling through the phase 2 reactions referred to as conjugation reactions. Conjugation means you add a special group to the existing compound. When you add a special group to the existing compound, you're converting one compound into another compound altogether. But ultimately, what is the concept of detoxification of xenobiotics? You're trying to convert a potentially toxic compound into a non-toxic compound, or at least a less toxic compound. And how do you achieve this? By converting a water insoluble compound into a water soluble compound. By converting an water insoluble compound into a water soluble compound, you are able to excrete the compound faster without interacting much with your body biochemistry. So you're converting a toxic compound into a non-toxic or a less toxic compound. And sodium benzoate is the salt form of benzoic acid, and this benzoic acid is conjugated using glycine. So benzoic acid is extracted from sodium benzoate that will react with coenzyme A, which is active form of pantothenic acid, to become benzoyl-CoA. This benzoyl-CoA will react with glycine to form something called as benzoyl glycine. This benzoyl glycine is soluble in water and can be excreted by the kidney through urine. And this benzoyl glycine has a name called as hippuric acid. So benzoic acid per se doesn't have a nitrogen, but once it becomes hippuric acid, the hippuric acid has the nitrogen that has come from glycine. So for this question, the amino acid who donates nitrogen to benzoic acid is glycine to form benzoyl glycine or hippuric acid. Okay, now look at this amino acid and the products. Amino acids given were tyrosine, tryptophan, cysteine, and histidine is what some students said, and the products given were norepinephrine, melatonin, glutathione, and histamine. So it's very simple. Let's look at tyrosine. Tyrosine is nothing but para-hydroxyphenylalanine. So tyrosine and phenylalanine, both of them are aromatic amino acids. So phenylalanine undergoes one step of hydroxylation process, which is a monooxygenase process to become tyrosine. And tyrosine is the parent for some special compounds like melanin, and also it is important for norepinephrine, epinephrine, dopamine. All three are referred to as catecholamines. Also, tyrosine is an important source for thyroxine. Three major things that you have to know with the respect of thyroxine. So on that basis, the answer is norepinephrine coming under catecholamine pathway. Now, what are the special products coming out of tryptophan? Tryptophan can give rise to serotonin. How? Tryptophan will become 5-hydroxytryptophan. And that 5-hydroxytryptophan will undergo decarboxylation to become 5-hydroxytryptamine. That 5-hydroxytryptamine is serotonin. This 5-hydroxyserotonin will go for acetylation in one step and then methylation in one step. Methylated acetylated serotonin is referred to as melatonin. While serotonin is capable of maintaining your mood and gives you a sense of security and also increases the BP in the blood vessel, while melatonin is capable of maintaining your circadian rhythm. Remember, melatonin is capable of maintaining circadian rhythm, and the source of melatonin is pineal gland in your brain, while melanin is important for giving pigmentation to your skin and iris and different parts of your body including hair. Now, what about the other compounds coming out of tryptophan? Tryptophan is also the source of hydroxyindole acetic acid, which is an end product. Tryptophan will be an important source of niacin. So niacin is a vitamin that can be produced from an amino acid called as tryptophan. Now what about glutathione? Glutathione has a full form like this, which is gamma glutamyl cystinyl glycine. So this is a pseudopeptide. Why pseudopeptide? This is a tripeptide, also called as a pseudopeptide, because the peptide bonds are generally formed in the alpha position. So, but this is the only condition where the glutamic acid's gamma carbon is undergoing a bond with that of a cysteine, and then cysteine will have an alpha bond with that of glycine. So this is the reason why it is called as pseudopeptide. Glutathione is formed from gamma glutamyl cystinyl glycine. So we go for glutathione for cysteine. And histidine is an amino acid. When this is undergoing decarboxylation using pyridoxal phosphate, it becomes histamine. Histamine is a mediator of allergy. So please remember, tyrosine, norepinephrine, tryptophan, melatonin, cysteine, glutathione, and histidine, histamine. This is the matching, which does not show HAGMA. What is HAGMA? It is high anion gap metabolic acidosis. High anion gap metabolic acidosis. When does high anion gap metabolic acidosis happen? When there is an accumulation of organic acids. When you find actual organic acids being added to the circulation, then you can expect HAGMA to happen. What is anion gap? If you have sodium and potassium on one side and subtract the bicarbonate and chloride on the other side, then this number should be between 8 to 12. Anything less than 7 and anything more than 12 will be abnormal. So if it is less than 8, it is LAGMA. If it is more than 12, it is HAGMA. In spite of acidosis, if the value maintains between 8 to 12, then it is called as NAGMA, normal anion gap metabolic acidosis. Now, in case of high anion gap metabolic acidosis, accumulation of acids happen. In diabetic ketoacidosis, ketone bodies are accumulating, which are acetone, acetoacetate, beta hydroxybutyrate, and these acids on accumulation will cause a higher anion gap. Now, in case of inborn errors of metabolism, many organic acidureas can be noticed. Organic acidemias can lead to accumulation of organic acids. In renal failure, there is a failure of excretion of organic acids, and there is also accumulation of organic acid metabolites. So accumulation of acids per se will be leading to increase in the anion gap. So DKA, inborn as a metabolism, and renal failure can cause high anion gap metabolic acidosis. While in case of diarrhea, you will be having NAGMA, normal anion gap metabolic acidosis. Let me add some more information to this question. Look at this part. When you go for NAGMA, what are the other causes generally? See, in case of GI, bicarbonate loss, this acidosis is not because of accumulation of acid, it is because of loss of base. So bicarbonate loss. Apart from that, you can also see them in case of ileostomy or colostomy drainage, or in case of fistulae. Now, not just the GIT, even renal bicarbonate loss will be able to cause the same. Example, you can have renal tubular acidosis, where accumulation of acids is not the primary problem, it is the inability to acidify the urine. As in case of RTA type 1, or it can be because of defective bicarbonate reabsorption, as in case of type 2, or you can also have them in case of hypoaldosteronism. Okay, now you will be having impaired ammonium excretion. In case of hypoaldosteronism, you can have decreased ammonium excretion. Apart from them, NAGMA can be found in case of carbonic acid or carbonic anhydrase inhibitors like acetazolamide. Then you can also have chloride containing acid load, which can lead to NAGMA, because chloride becomes a part of the anion gap calculation. So whenever you have acid which is because of chloride, then it can also cause NAGMA only. For example, if a patient is having hyperchloremic acidosis, or when a patient is being given ammonium chloride, in those conditions also you can have NAGMA. So what are the other conditions? When a patient is undergoing total parenteral alimentation or total parenteral nutrition, or in early kidney disease also you can have NAGMA. I've said all these things because you should be able to answer the same questions or similar questions in the future. HAGMA, accumulation of an actual acid. NAGMA, accumulation of acid, organic acid is not the primary content. Either you are unable to reabsorb the basis, or you're losing more amount of basis, or you are not able to throw out the ammonium. Ammonium is a potential candidate for causing ammonium chloride, right? Also, chloride containing acids load will not be taken as organic acidemia, because of which their accumulation can lead to normal anion gap metabolic acidosis. Okay, now this is a very beautiful question. Diabetic patient with raised triglyceride and VLDL. What do you understand from this? See, triglyceride is actually glycerol plus 3 fatty acids. Now this triglyceride is present in 90% components in case of chylomicron, and 60% composition as a part of VLDL. 90% of chylomicrons are also made up of triglycerides, and 60% of VLDL is also made up of triglycerides. Now, when there is a raise in the triglyceride and also in the VLDL, which is the correct answer? For this, you have to understand what is the role of each of the enzyme. First, look at the concept of lipoprotein lipase, and then look at the concept of hormone sensitive lipase. Lipoprotein lipase is also a lipase. Hormone sensitive lipase is also a lipase. But the difference is this lipase attacks the lipoproteins. It means you are targeting the circulating triglyceride carrying vessels, while hormone sensitive lipase is targeting the triglycerides present in the adipose tissue. This is the gross difference I would want you to remember. While hormone sensitive lipase is sensitive to the hormones, that is most commonly the powerful controller is insulin. Insulin keeps the HSL in the inactive state. Well, lipoprotein lipase alters itself depending upon the lipoprotein concentration present in the blood. Now look at this. When LPL is taken into consideration, it hydrolyzes the triglyceride that is present in the VLDL or kilomicrons. The reason why I told you about kilomicrons and VLDL is that you have to know triglyceride is present in the VLDL and kilomicrons. Triglyceride is accumulating inside the adipose tissue also. LPL will break open the triglyceride from that of VLDL and kilomicron, because of which you will be able to see triglyceride elevation. But if you focus on the HSL will be able to break open the triglyceride from the adipose tissue. Now look at diabetes. In diabetes, you can either have type 1 diabetes or you can have type 2 diabetes. In case of type 1 diabetes, insulin is absent. In case of type 2 diabetes, insulin may be present or it may be elevated. But the point is, control on the HSL is absent in case of type 1 diabetes. And when there is loss of control on HSL, then HSL level will start increasing. And when HSL level increases, you will be able to release the triglyceride from that of adipose tissue, because of which you will be able to notice triglyceride levels elevating. But LPL level cannot be elevating. Why? Because LPL, if it is elevating, then VLDL will be broken, so triglyceride will be elevated, right? So VLDL should be lesser. So if LPL is elevated, VLDL should be less. But here LDL and VLDL are also elevated. Forget about the LDL. Here VLDL is elevated. If VLDL is elevated, it means VLDL is not broken. That means LPL is not playing a role. So LPL decreases, HSL increases. I'll repeat, HSL will act on the adipose tissue. So when the adipose tissue triglyceride is broken, triglyceride levels and free fatty acid levels will increase in the blood, and that happens in case of diabetes. Because in diabetes type 1, insulin is absent, because of which HSL is activated. So when HSL increases, the triglyceride levels will increase. But VLDL may increase or may not increase, it doesn't matter. But if you focus on LPL decrease, then LPL is not available to break down the VLDL, because of which VLDL increases. So simply, LPL decrease is causing VLDL elevation, HSL increase is causing triglyceride elevation. This is the best option possible. Not a cytochrome C oxidase inhibitor. Cytochrome C oxidase is the scientific name of complex 4 of electron transport chain. Complex 4 of electron transport chain is capable of taking the electrons from the complex 3 or cytochrome C. That is, through cytochrome C, it accepts the electrons from complex 3. From cytochrome C, the electrons will go to complex 4 and the electrons will be offered to oxygen. So it is cytochrome C oxygen mediator. It is referred to as cytochrome C oxidase. And there are important compounds who can inhibit the cytochrome C oxidase, which include cyanide, hydrogen sulfide, carbon monoxide. The only one who is not inhibitor of cytochrome C oxidase is nitric oxide. So please make a note of this. Nitric oxide does not have a role in cytochrome C oxidase inhibition. But nitric oxide is also a second messenger which is capable of causing relaxation of smooth muscles present in the blood vessels. It is also an important mediator in other cells also. Now, patients with symptoms of SACD, history of gastrectomy, which vitamin deficiency. You don't even have to go to SACD. If gastrectomy is taken into consideration, it means the stomach has been removed or at least partly removed, because of which HCl producing cells are going down. Oxyntic and parietal cells are going down, because of which intrinsic factor production is also going down. When intrinsic factor production is lesser, no matter how much amount of the extrinsic factor called as vitamin B12 is present in your food, that extrinsic factor does not have a binding with that of intrinsic factor, because it is not there. So when extrinsic factor comes into the smaller intestine, remember the golden rule. Absorption of extrinsic factor called as vitamin B12 happens only as a part of a complex. Only the complex is absorbed. Only the complex is absorbed. That is, extrinsic factor, intrinsic factor complex alone is absorbed in the intestine. How do you remember? See, if I write F here and I remove this bar and I rotate it this way, it looks like this, or it at least looks like this. This J looks like jejunum. So folic acid is absorbed in the jejunum, iron is absorbed in the duodenum, and the only thing remaining is vitamin B12, which is absorbed in the ileum. So absorption of vitamin B12 in the ileum happens as a complex between extrinsic factor and intrinsic factor. For a person who has gastrectomy undergone, his ability to produce intrinsic factor is lesser, because of which extrinsic factor complex is not found. So EF absorption is poor. When the EF absorption is poor, then the patient will have vitamin B12 deficiency when vitamin B12 is taken orally. That is why injectable form of vitamin B12 alone can help this patient. And when there is a vitamin B12 deficiency, it can have two roles. One is in the blood status, which can cause megaloblastic anemia, and in the CNS, methylation fails and DNA maturation fails, because of which the patient can have subacute combined degeneration of spinal cord, the worst form of B12 deficiency manifestation. So neurological symptoms and that of your blood symptoms will actually become severe. Baby with breast milk jaundice, all are correct except most babies need phototherapy. Jaundice is unconjugated. See, whenever you think about breast milk jaundice, the breast milk carries certain kind of compounds or factors. They generally inhibit the normal processing of bilirubin. The normal processing of bilirubin actually involves one of the important steps called as conjugation. So this will inhibit the conjugation. That means the bilirubin remains unconjugated. So this jaundice is unconjugated hyperbilirubinemia. At the same time, this happens usually after first few days of life. And you will be able to make a diagnosis of breast milk of jaundice or breast milk jaundice not by directly going for breast milk jaundice. It is by eliminating all other diagnostic processes. Eliminating all other differential diagnosis, you can make a diagnosis of breast milk jaundice. Now, what about phototherapy? Phototherapy is important for causing photostereoisomerization. When the UV light falls and when the sunlight or any artificial light is falling, it is capable of converting bilirubin from one form into another form, which can become more soluble. Otherwise, the accumulation of bilirubin cannot be cleared. So, phototherapy is important for making it more soluble. The point here is most babies with breast milk jaundice, as the condition is mild, it resolves spontaneously because the load is not very high. This phototherapy is actually reserved for very severe unconjugated hyperbilirubinemia. For example, if a child is undergoing ABO incompatibility during transfusion reactions, or there is an RH incompatibility, massive hemolysis happens, in those conditions you can go for your phototherapy. But here, most babies don't need phototherapy is the right answer. That is why option A is the right answer here, because there is the exceptional statement. Now let's look at the 11th question. This is slightly a difficult question for many people to comprehend, because this is not seen many times when you're preparing for your entrance exams in biochemistry. This is a purely laboratory based question. So let us try to understand what the collection process happens for calcium. Whenever the calcium is sent into the machine, that is the sample is sent into the machine for estimation of calcium, it is called as analysis. But before you send the sample into the machine, how do you collect the sample? How do you preserve the sample? What do you add to the sample? What do you pre-process the sample? All of them come under pre-analytical procedure. This question is mostly a pre-analytical question rather than analytical question. So for that reason, let us look at this theory here. See, patient preparation and the manner of specimen collection can significantly alter and affect the results of total and free calcium determination. Point number one. How do you collect? Point number one, a common and important source of pre-analytical error is the measurement of calcium is the increase in total but not free calcium concentration whenever there is a tourniquet and venous occlusion happening during sampling. So whenever you tie a very tight tourniquet and you try to occlude the vein so that the veins will bulge, then you draw your blood, it can lead to total but not free calcium concentration increasing. So let me write this. When tourniquet is used, free calcium remains the same, but total calcium increases. This is point number one. Okay, remember this. Next, you have an understanding of how much amount of errors can happen. Errors of 0.5 to 1 milligram per deciliter in total calcium may result from the increase in protein-bound calcium caused by the efflux of water from the vascular compartment during stasis. You try to tie up the vein very tightly, because of which the blood that is accumulating in the veins are very thin-walled kind of blood vessels. So you will be able to see efflux of water happening. And when the efflux of water happens, protein concentration may increase, because of which the calcium will start binding to the protein. So stasis can lead to fall in the free calcium or normal calcium, but approximately apparent total calcium can increase. Next, only small and clinically insignificant increase in free calcium have been reported with venous stasis. That is another statement. If a tourniquet is required, it should be applied just before sampling and released as soon as possible. That is what is to be understood. Fist clenching or other forearm exercises should be avoided before phlebotomy. Phlebotomy means putting the needle and drawing blood. So fist clenching or other forearm exercises should not be done. Why? Because forearm exercise causes a decrease in the pH. Why? Continuously when you keep doing this, there is a sudden burst of physical activity, because of which lactic acid accumulation can happen. So local pH value will fall. And when that happens, an increase in the free calcium happens, because of which muscular activity or clenching can lead to fall in pH, which will lead to increase in free calcium. Okay, now changes in posture cause fluid shifts within 10 minutes and thus alter the concentration of cells and large molecules, including albumin and total calcium. See, why total calcium is always capable of having this change? Because calcium, a part of the calcium can be albumin bound. So whenever there is a change in posture, because of which the content of the albumin inside the blood vessel alters, then automatically total protein also will change. So standing decreases the intravascular water and increases the total calcium. Why? When you stand, the blood has to pump against the gravity, so they are not able to pump very efficiently. Some of them can be lost through the blood vessel wall, because of which water content can be lost from the intravascular compartment. That makes the total calcium concentration increase by 0.2 to 0.8 milligrams per deciliter. Now, if a patient is recumbent, that is, he is lying down, it has the opposite effect. It means a smaller effect has been reported for free calcium. One partial explanation for mild hypocalcemia observed in many hospitalized patients may be hemodilution associated with recumbency. If a person is lying down, water is not escaping because of gravity, so water stays inside the blood vessel, and when the water content is increasing inside the blood vessel, it may lead to hemodilution, because of which they may be mild hypocalcemia, because the water is a solvent. When the solvent levels are increasing, the solute called as calcium as analyte is decreasing relatively. Okay, this effect can be observed during 24-hour sampling of normal individuals. Prolonged immobilization and bed rest increases bone resorption. If a patient has not been working hard and if he is always bedridden, then he is not using his muscles. When the muscles are not being used, the bone remineralization does not happen. So this increases the bone resorption. The calcium from the bone will be removed, because of which there is increase in total and free calcium. Hyperventilation and exercise decrease and increase the concentration of free calcium respectively. That means whenever you have hyperventilation, the PCO2 will fall. Because of PCO2 fall, the pH will elevate. When the pH will elevate, then in alkaline pH, what happens to the calcium? See, calcium contains a positive charge, while the albumin will contain more strong negative charge, because of which calcium will tightly bound and strongly bound to the albumin, because of which free calcium will fall, which can give you clinical features of hypocalcemia. Now look at this part. In case of exercises, pH is decreasing. I told you about the lactic acid accumulation. When the pH is decreasing, free calcium increases. When the pH is increasing, free calcium decreases. So these two make a very good statement. Both plasma free calcium concentration and calcium excretion are decreased during the night. This is another information. Food ingestion has been reported to have various effects, but usually causes a mild increase in plasma calcium. Ingestion of calcium salts may increase plasma calcium. Hemolysis can alter free calcium because of dilution, alteration in the pH, and binding. Now, sodium perchlorate used in treatment of hyperthyroidism may falsely lower the results of free calcium measurement. I have given you all the possible pre-analytical ways by which calcium levels can give you a false answer. Now let's look at the question. While collecting blood sample for calcium, which of the following is avoided to prevent false high raised calcium values? Now try to answer this question on your own. This is the homework I could give you. I have given you enough information to look at this. Use a tourniquet and release immediately after drawing. When you do it, I have told you, right, it is possible. When you release immediately, what can you do? Come on. I would like you to focus on this area here. These are all the areas where the answer has been given. I told you, if at all you're doing, a tourniquet is required. If a tourniquet is required, it should be applied just before sampling and released as soon as possible. This can avoid some amount of changes. So it can be avoiding the prevent false high, raised or falling, false low calcium values also. Would not collect after exercise. Yes, would not collect after exercise means what? If after exercise, pH level is decreasing. When pH level is decreasing, calcium levels can increase. So this is not correct. Making a fist is not recommended, the same as exercises. Remaining immobilized for long hours would result in resorption, giving falsely elevated value. So calcium level can increase because of osteoclastic activity. So this is a true statement. Making a fist is not recommended because of low pH, the calcium levels will be higher. This is a true statement. Would not collect after exercise because after exercise pH is lesser, calcium level should be higher. This is a wrong statement. Use a tourniquet and release immediately after drawing. That is an acceptable statement. So among these, the false statement may be this. If they said would not collect after exercise because it can cause fall in calcium level, that may be the false statement. Otherwise, I do not know exactly the proper wordings verbatim. I have just written this from the hearsay moment from the students who have come back. So I have given you enough information to solve this question on your own. Now there is one more question where they spoke about aneuploidy. Aneuploidy is best understood by four options they had given. One is fluorescent in situ hybridization. Second thing is conventional karyotyping. Third is PCR. Fourth is Sanger sequencing. This is what I believe the students have told me. So remember, FISH is a molecular cytogenetic techniques that uses fluorescent probes. Point number 1. It targets specific zones or specific regions on chromosomes. So the best option can be FISH. To read and understand aneuploidy, the best option is FISH. So you will be able to visualize those kind of abnormal portions in the chromosome using fluorescence microscope also. So aneuploidy detection can be very effectively done. You will be able to identify extra chromosome in the form of trisomy or any missing chromosome in the form of monosomy can be done using FISH. Then what about conventional karyotyping? See, you will be able to, if you're going for conventional karyotyping, it involves visualization of entire set of chromosome. Entire set of chromosome. You will be able to know the number, size, shape of all the chromosomes. It may be time consuming. So for this question, the best answer should be FISH followed by conventional karyotyping. When you go for PCR technique, you are looking for an individual mutation and you're trying to replicate it into millions. So PCR is not important or enough to understand the regional chromosomal missing. So aneuploidy cannot be seen using PCR. Sanger sequencing is capable of telling individual nucleotides present in a sequence. Again, this cannot be helpful for identifying aneuploidy. So the best answer for this question is FISH followed by conventional karyotyping. I hope this will give you enough information to carry on forward for your preparation towards NEET PG 2025. All the very best for your preparations. Thank you, and you can download the app and watch all the videos that has been teaching you the same thing for the last. All the questions that has been taught here have been taught in the videos except this question about the calcium, because this is a googly question from that of INI-CET. It is a purely a pre-analytical question and it is learned by generally MD biochemistry students. I hope you will be able to remember this for your exams also. All the very best.